This episode of Doc Talk is brought to you by the Kappa Boot Scootin' Ball, featuring the president of the Redneck Yacht Club himself, Craig Morgan. Join us Friday, April 5th for the Knoxville's most talked about fundraiser of the year. The event will be packed with great country music provided by Craig Morgan, line dancing, Western-themed dinner, bottomless beverage, and an exclusive Kappa Boot Scootin' Ball souvenir mug. Additionally, a silent auction valued at more than $40,000. We have the opportunity for those in attendance to bid on some packages, including a Dynasty Spa. For tickets, visit kappabootscootin.com.
Hi, and welcome to Doc Talk. Doc Talk is the Knoxville Academy of Medicine podcast where we talk about health issues involving all East Tennesseans in plain language. I'm Elise Denaney, former president of the Knoxville Academy of Medicine, and I'm so glad that you are here to join us today to talk about something which is very, very prevalent, very common in East Tennessee these past probably decade at least. And joining me to help understand the problem today is Dr. Pinzon.
Right.
Did I pronounce that correctly?
That's perfect. Yes,
I am
exactly.
so sorry if I haven't. Who is a physical medicine and rehabilitation physician, which is, some people call that PMONR. So explain to us what PMONR is all about.
PMONR is basically it's physical medicine and rehabilitation, where we primarily emphasize most of our training in mostly musculoskeletal type care. So a lot of what we do basically is trying to help people either rehabilitate from a condition, health condition that they've been injured. In my field, I'm an interventional spine and musculoskeletal specialist, where I had a fellowship training primarily to minimize a lot of pain-related conditions related to either musculoskeletal or spine. But there's really two sections of physical medicine rehabilitation. There's a physical medicine part, which is what I am, and then there's a rehabilitation part, which I incorporate, where there is more inpatient type skill, wound care, spinal cord injury, traumatic brain injuries, things like that. I'm more of a physical medicine of the rehabilitation part, and so I do a lot of interventional spinal musculoskeletal type care and so forth.
It's amazing. I mean, it covers so much. I remember when I was subbing for my children's, biology or health class or something, and we were just talking about what bones are. And they were saying, okay, just imagine, if you took every bone outside of your body, your entire skeleton, then your skin would just go flat as a pancake. So it is the bones that keep us upright.
Right.
And unfortunately, over time, there is a lot of wear and tear on them.
Correct.
Or if we carry a little bit of extra stress on them, there's more wear and tear, or if we're an athlete.
Right.
So it's amazing. Which area of the body seems to suffer the most damage?
From my standpoint, a lot of it is spine, and you touched on a good point. We're all weekend warriors to a certain degree, and so there's a lot of sports-related injuries, or there's a lot of us who like to do extracurricular activities such as skiing and different sporting and so forth, and so a lot of it is covered through the spine. We have a lot of people that have neck, lower back problems where they don't necessarily want to have a significant surgery where that would involve either a fusion or discectomy. A lot of times you can manage these things, a lot of times through interventional procedures to minimize a lot of the pain. May not resolve completely their pain, but to a certain degree it'll get rid of a lot of their symptoms, therefore it allows them to be able to function without having to undergo, let's say, a major surgery which may incapacitate them for a period of time from work or leisure activities.
It's really good to know, because there are perfect example. Somebody who is in the C-suite of a very high corporation, high-powered, and he's sitting at the computer all day, carries a lot of tension in his neck, and he just has or she does have chronic neck pain. And not enough time, not only that, doesn't have the desire to rehab, having surgery where they cut you in the front of the neck or cut you in the back of the neck. And so knowing that what you do is an option is brilliant. So what would you offer them?
So that's a good point. Let's talk about neck pain, for instance.
Sorry. Yeah, okay.
But that's a good. I mean, lead into, because there's a lot of us who are on computers or we're on our phones, and so there's conditions that physicians who are in the OR a lot or doing procedures basically are on phones. There's a condition called text neck, let's say, where a lot of a lot of us are on the phones and so forth, and as a result of that, they're starting to develop more neck problems or other musculoskeletal conditions in the back of the shoulder. So, what do I do about that? Well, a lot of times I incorporate. I try to minimize the use of medications. I may give them some anti-inflammatory medication, muscle relaxants, but we try to incorporate physical therapy right off the bat, where we have to make the right diagnosis in order to incorporate the therapy, be able to make the right diagnosis, and then after that, then you can try minimal procedures such as local intermuscular, let's say trigger point injections, local injections that may help minimize some of the muscle spasms, and then incorporate injections such as, let's say, medial branch blocks or facet joint injections, which will go inside of the joints. And I brought a couple models. I brought a model here, but let's say a lot of times as we are starting to get older and so forth, a lot of the problems that we have tend to occur usually along this area right here, where the muscle is attached. These are the joints. So this is the back of the spine, let's say. This is the front of the spine. So a lot of times what's happening is that we're starting to develop arthritis, a lot of times in the joints. And when you develop arthritis, then you can hear a lot of that.
So does that wiggle?
Yes, so it can wiggle back and forth.
Okay.
So that's as if you're flexing the neck forward or extending it back.
Okay.
So many times, you hear some of that snap, crackle, pop in the neck and say, "Oh, doctor, is that normal?" And
I hear that all the time.
Right, and so a lot of times that's the joint that's arthritic,
Okay.
and a lot of times what we can do as physicians either try local injections just in the muscle bulk, which is where the muscle's attached up here by the joints, but you can also go inside of the joints or along the side here where the sensory nerves occur, and you can try to block the sensory nerves or go inside the joints. And you can try different procedures that may be able to relieve that pain. You can even try to lesion or burn some of the sensory nerves, and that may give you more relief for a longer period of time, sometimes for months to years. Sometimes people have had surgery, let's say, and they have had surgery. It resolves a lot of their leg pain or arm pain, but they're still having, "Oh, gee, doctor, I have some neck and lower back problems." We can maybe be able to do some procedures on that segment to be able to reduce a lot of their symptoms from that standpoint. So
That's great. And is it 1, 2, 3?
yeah, so it depends on the patient. A lot of times if they have more, let's say, leg or arm pain, we call that radicular pain, then we can try, let's say, epidural injections. You can try different approaches. You can try what we call a transforaminal approach, where you come in from the side, basically try to come closer toward where the nerve goes, because that is what causes the arm or leg pain. Or you can try more of a midline approach, like an interlaminar approach. So sometimes I try to not increase as many of the number of procedures as much as try to distinguish the procedures to be separate in order to distinguish, number one, what are they getting more relief from? Is it more of the axial or more back or neck pain, or are they getting more relief from the pain that goes in the arm or leg called radicular pain?
Okay. And so the injection, they don't have to worry about then that they can't use their arm.
Right, exactly. So everything I do is done under fluoroscopy. That means an X-ray machine where I can see live views. I can inject contrast material to make sure I'm in the right location at all times. If I'm not happy with the location, you can move the needle around in order to localize that, and therefore it allows it to be much safer. It's not what we call a shotgun approach, where you're just kind of trying to figure out if you're in there or not. I mean, everything we do there's a science to this. You want to make sure it's accurate. You want to make sure that you're in a safe location at all time, and then you inject the medication. Usually it can be an anesthetic like a lidocaine or marcaine, but you may incorporate some steroids in there, and it's not the anabolic steroids that you build your bulk, it's more the anti-inflammatory type steroids.
Okay, so you mentioned three chemicals: lidocaine, marcaine, and
then the steroid.
Okay, and those are like the ingredients that help to alleviate pain.
Exactly. So it can either alleviate the pain for a short period of time, such as the anesthetic part, the lidocaine, marcaine, and then there's steroids, which tends to reduce it for a longer period of time. If you need to go on to the next level of treatment, where you lesion nerves, let's say what we call radiofrequency ablation or neurotomy, then in that case you would actually burn the nerves, and then you put a little steroid on there to reduce some of the inflammation. After you burn the nerves, many times it'll take 4 to 8 weeks for the nerves to basically die away or denervate, and then basically the symptoms will go away for months, sometimes years for some patients. I've had patients 10 or 12 years of relief, and you know, I tell them to expect 6 to 18 months, but it can definitely last for months or years.
So to figure out, before we leave the neck, and then go down to the back, because it's all one line, to figure out where the problem is, do they have to have some sort of x-ray?
Right. So a lot of times that's a good observation. A lot of times we always have to, you know, part of how we treat is making the right diagnosis. It occurs in your field, occurs in mine, and so forth. You make the right diagnosis, you're able to assist the patient much faster. So a lot of times, number one, I was taught that a good exam is always the key element. So I look at all the diagnostic data, any notes that were given to me from the referring provider, whether it be primary care or specialist. I look at all the notes, I examine the patient, we talk about, you know, what your problem is, and then I try to distinguish, this is more than likely your problem. About 90% of the time, that will give you your information about what your diagnosis is, and then I'll either incorporate the x-rays, MRIs, CT scans, a lot of times electrodiagnostic testing. I do sometimes testing when you're confused. A lot of times when you look at an MRI or CT scan, it's confusing because you can say, well, your pain is on the right leg, but your MRI shows that you have pathology on the left. So I'm a little confused. Let's send you for electrodiagnostic or EMG testing, where we can make that distinguishing, number one, which nerve is involved, or is there no nerve involved? So a lot of times we do incorporate all the diagnostic testing, correct?
That is wonderful. Okay, so now I'm going to move from the neck down to the back.
Okay.
And you've brought along a wonderful friend. I don't know, he have a name?
Yeah, I think, I guess Ted. You know?
So glad you could join us today, Ted. And thank you for allowing yourself to help us understand the back. So talk to me about back pain.
So in back pain, that's majority of the pathology I see as a spine musculoskeletal specialist. So a lot of times the back, just as we showed here on this model of the back of the spine, incorporates a lot of your pain, and that you tend to have mostly with people that are either tend to a lot of sitting type activities, such as sitting in a desk, computer work, and so forth. But there's a lot of manual workers that we have that injure their back all the time. If you have, let's say, a lot of times pinched nerves, then a lot of times what happens is that there's little small foramen, we call them, or the openings where the nerves come out, which may involve. And so a lot of times people say, gee, I have leg pain. What's causing the leg pain? It's not down here. This is not the source of the pain. Many times it's coming from up here, but it creates a referral pattern. And so after years of studying these problems, you can distinguish that a lot of times where the referral pattern, it may go from this nerve, and certain nerves give you certain pathways that you can distinguish. Let's say a nerve in this level will give you more pathology in the back of the leg, sometimes to the bottom of the foot, sometimes to the top of the foot, let's say, similar into the arm and so forth. So many times when you have that radicular pain, it can become as a result of a herniated disc, or sometimes stenosis, which just means narrowing of the canal. Sometimes when you have back pain, let's say, just strictly back pain with no leg pain, usually occurs more into the joints, or the back of the spine, let's say.
So they look like they're so perfectly balanced and articulated together.
Right.
When one of them goes out of whack, does it impact on the other ones also?
It does. And so many times if you have, let's say, one segment that is out of alignment, let's say, then you can either refer this a lot of times to a physical therapist, or let's say a chiropractors, which do similar type work. And a lot of times you can try to see if just a simple realignment of the spine may be helpful. If it's not, then we start incorporating other treatments such as the local injections or the deeper spinal injections and so forth. So yeah, alignment has a lot to do with these problems. I see a lot of scoliosis patients, and a lot of times that's a difficult case because let's say they're much older, let's say, a lot of times, and so a lot of their pathology usually at least in my treatment, usually occurs more in the muscle, but a lot of times mostly in the joints it tends to occur a lot more.
Yeah, and scoliosis is interesting. It's one of those things that it's been there for so long,
Right.
that there's a lot of muscle and tendon and already configuration that you can't change.
Right. And a lot of times the new school of thought is that if you can treat it early in the process, let's say when you're in your teens, you can avoid a lot of these complications, because there's a lot of, when you get older, a lot of times you develop scoliosis, let's say, and then you start developing osteoporosis, which is more of a, let's say, a decrease of mineral content in the bone. And so then you have catch-2 kind of problem. You have decreased bone mineralization, plus you also have the curvature of the spine, which causes its own complications and so forth.
So is pain usually the first presenting symptom of something wrong in the skeletal?
Yes. So that's usually when patients usually say, well, I thought my back or neck hurts, and gee, I thought it was going to go away. I tried some medications, doctor. Geez, I did some stretching exercise. It hasn't gone away. This is becoming a problem for me, and therefore they come to see the doctor. Or a lot of times they'll see the family doctor. The family doctor says, well, this is not what I treat. Let's refer it to someone like Dr. Pinzon, and he'll evaluate this and so forth. So a lot of times, many times, at least in the state of Tennessee, patients can go to a physical therapist without a physician prescription. And therefore, a lot of times they can go up to, I believe, up to 6 sessions and so forth. If they're not showing improvements, the therapist have to send it to a provider who will have to do an evaluation, because there could be a lot more involvement that they'll need to look at, the diagnostic testing, let's say.
That's fascinating. Yeah. So I didn't know that about physical therapy.
Yeah, it's true. Yeah, and so a lot of patients, just like they can go to a chiropractor, they can. I tend to incorporate physical therapy in my practice much more, because if you look at the data out there, the data states that people tend to do better with the incorporation of not only the spinal injections, if you have to have them, but with physical therapy.
Okay. Final question. Okay. Do the injections hurt?
It depends. Everyone has a higher, lower threshold and so forth. So I've had injections, and I've never been sedated for them. And as a result of that, I say that sometimes, all needles are sharp. And so I expect you to have a little bit of pain, but it's not incapacitating. But many times I will have patients either under sedation. It's a local sedation, like a conscious sedation, let's say propofol, and short-term type medication. Or I do a lot of these procedures in the office where I give patients Valium. They're awake. We talk them through it. We have a little music in the background. The nurse basically explains the procedure. A lot of times they don't even know the procedure's over by the time we're done. So
I think that's the way I'll do it.
Exactly. Exactly.
So, Dr. Pinzon, if people need to get a hold of you, how do they get a hold of you?
So, I have a practice called University Spine and Sports Specialist. Our phone number is 865-690-3737. We have a website through either Facebook, LinkedIn, and we also have our own private website, www.usss-volunteer or vchrm.com, which is Volunteer Comprehensive Health. So we incorporate a spine practice, also regenerative medicine practice in there. So.
Regenerative medicine, that's a whole new field. Thank you so much for joining us today. So interesting to hear about physical medicine and rehabilitation, how you treat chronic neck pain, chronic back pain. I think probably number 3 in our area. Everybody has chronic back pain and has pulled their back at one time or another. So it's always good to know that you're out there to help us.
Great.
So thank you so much for joining us, and we hope you'll join us again soon. And that's a wrap.
This episode of Doc Talk is brought to you by the Kappa Boot Scoot and Ball, featuring the president of the Redneck Yacht Club himself, Craig Morgan.
Trackers, bayliners, and a party ball.
Join us Friday, April 5th for the Knoxville's most talked about fundraiser of the year. The event will be packed with great country music provided by Craig Morgan, line dancing, Western-themed dinner, bottomless beverage, and an exclusive Kappa Boot Scoot and Ball souvenir mug. Additionally, a silent auction valued at more than $40,000 will give the opportunity for those in attendance to bid on some packages, including a Dynasty Spa. For tickets, visit kappabootscootin.com.